Good afternoon. I'll be presenting this on behalf of the team from UCLH. We have no conflicts of interest to declare. So as you probably know, at the moment there is a mesh pause in the UK. That's because of the concerns about complications from the mesh surgery. Our study focused on urethral complications in view of their rarity and relatively unknown functional outcomes. We performed a retrospective analysis over a 10-year period. All our patients had urodynamics preoperatively and video urodynamics postoperatively if indicated. We identified 35 consecutive patients with a median age of 54 years old, with a median time between the index tape insertion and tape removal of 5 years. Preoperative urodynamics revealed stress urinary incontinence in half and wet or dry DO in 11% respectively. This is just an outline of the initial management. All apart from one had vaginal excision, repair of the urethra, and Marshall's fat pad interposition were technically feasible, apart from one which had a new bladder and Mitrofanov. 3 patients had simultaneous stress urinary incontinence surgery. Unfortunately, in all 3 of these, the stress incontinence surgery failed. Overall, there was a 74% risk of persistent or recurrent incontinence, and these patients went on to have repeat video urodynamics, revealing stress urinary incontinence in 81% and dry or wet DO in 19%. Patients who had stress urinary incontinence went on to have further stress urinary incontinence surgery with an overall success rate of 75% of cure or improvement. This consisted of rectus fascial slings in 13 women, colpus suspension in 5 women, periurethral bulking in 1, and bladder neck AUS in 1 as well. So to conclude, vaginal excision, urethral repair, and Marshall's fat pad interposition was the most common surgical management of urethral erosion for mesh. Incontinence was recurrent or persistent in 74%, and 59% of patients required further stress urinary incontinence surgery with an overall success rate of 75%. Thank you so much.
Would you?
So 2 questions.
Yes.
Number 1, as far as the Marty's fat pad, is that just standard that's done in everybody? Because my personal experience is that usually the tissue looks pretty good and usually can get some nice coverage, and that we generally don't do that. And I'm not sure, it's not helping with the stress incontinence, so to speak. It's not giving you any bulk. So
it is standard practice if technically feasible. If it can be pulled into the surgical field. We found that actually at the time of subsequent surgery, it makes for much easier access for the repeat surgery if necessary. And also we published on the use of Marshall's fat pad from our cohorts. And actually the risks and what the significant adverse events for these patients are low. And also they don't experience necessarily any significant discomfort or sort of local abnormality related to intercourse, for example.
Can I ask one question?
Yes, please.
You prefer rectus fascial slings, do you? Or is that the preferable method in these cases? Or why did you, I think there are more of them than any other procedure?
I think it is guided by the video aerodynamic studies after the surgery, but if I may redirect the question to Mr. Hamid, who is in the audience.
we won't allow them.
Yeah, I'm going back. No, yes, I think we are dependent on the video dynamic studies. Quite often, these ladies will have type 3 incontinence, and rectus fascial sling probably works best in that scenario. We obviously, never is never, but they have an eroded synthetic sling. We do not use a second time a synthetic sling for that reason. Some of them had colpus suspensions, some of them had artificial sphincter, but by choice, it will be the rectus fascial sling.
Okay. Thank you.
What about so it looks like a minority of the patients had the concomitant stress incontinence surgery, and of those in that minority, they seem to all fail. So is your general practice to stage these?
Yes. I think those, because this is historical data from 10 years, those were the initial ones, and we found out if you do concomitant surgery at the same time, more often than not only it fails, but in a proportion, you might not need surgery. Either the patient doesn't want it, or the incontinence is not as bad. Therefore, now our standard practice is we'll do the primary surgery, whatever that might be, wait for at least 3 months, then reassess the patient, and then decide how to go forward. And we find that that works best.
We have a large series of using holmium laser for this type of condition. Can you want to comment on that? Why not?
Thank you.
We haven't, we don't do laser surgery. Some of our colleagues have tried that. In our experience, more often than not, they need repeat surgery. Maybe we don't do it as well as you guys do, but we as a primary procedure, we don't do that. We go in and do it open. I don't know what Howard thinks.
So I'm not the author, but I would agree. I mean, our experience is that we see a lot of patients get sent to us with little things sticking in, and it could be that they were not deep enough when they did the laser resection, but our personal experience is
It's
we
the same as
do
ours,
the
yeah.
same thing.
Did any of these patients were treated conservatively, like with estrogen?
No, unfortunately, these patients were referred for the visible urethral
They
erosion.
have tape extrusion, so the tape is exposed, so you have to remove the tape. With urine.
All right. I thought this presentation was going to arouse more controversy, but okay.
Thank
Thank you very much.
Thank you.